Koto, welcome to another MS Auckland webinar. My name is Penelope and I'm co-hosting tonight's webinar with Luminita. We're both community advisors for MS Auckland. And we're very excited to welcome tonight's guest speaker, Sarah Hopkins from Hibiscus Neuro Rehab. Sarah's a senior physio and a director at Hibiscus Neuro Rehab. She has vast experience with treating neurological conditions, including multiple sclerosis. And Sarah's going to be speaking about balance and falls in multiple sclerosis. So a fabulous topic to learn more about and relevant to many of our members. And before I hand over to Sarah, I'll let you know that we'll direct audience questions to Sarah at the end. So please feel free to type in your questions into the chat box or the question box as we go, and we'll keep these questions for Sarah at the end. Please keep them to a general nature so that they can relate to others as well. So without any further ado, I will hand you over to Sarah. Thank you, Sarah.
Thank you.
Thank you so much, Penny. Just start sharing my screen here. Thank you everyone for coming tonight and having me talk about this great topic on falls and balance with multiple sclerosis. As Penny said, my name's Sarah Hopkins and I'm the owner and neurological physiotherapist at Hibiscus Neuro Rehab, based on the Hibiscus coast in Auckland. So we see people in our clinic and in their own homes. Tonight, what I'm going to be talking about is falls and balance, and I'm going to be covering about how common falls are in MS and how common balance deficits are. I want to discuss what falls actually are, because sometimes these are underreported, and then look at how the balance system works. And then I'm going to look at multifactorial risk assessment and causes of decreased balance and falls, and then how we can address this. So if we look at the prevalence of balance deficits and falls in MS, and you can see the slide is quite a lot of stats on it and heavy, that's because there's a lot of information to show that this is a huge thing that happens and impacts. Up to 75% of people with MS report that they have a balance dysfunction, and about 50 to 56% of people with MS report falling, and this is often underreported and underdiagnosed. Within the group of fallers, 50% of people fall at least once in 6 months, with 37% of people falling recurrently, so more than once. And most of those falls, about 65% of them, actually occur between the hours of 6 a.m. and 6 p.m, so when we're doing most of our daily activities. 28% of people that fall sustain a fracture, and that's something that we need to be aware of. Injury post-fall, including fractures of the hip, fractures of the wrist, shoulder, head injuries, and other musculoskeletal injuries that can happen when we do fall over. Falling results in time off work in about 42 to 58% of cases. And what it's been shown is that balance and walking impairments are one of the most common deficits, and they arise early in the disease course and can occur in even mild to moderate disability before walking aids become a necessity, so quite early on. So I want to talk about what is a fall, because falls definitions can be confusing. We know that limitations in mobility and walking restrict the capacity for things like social participation and negatively impact health-related quality of life. Often people will think that a fall is like this definition here, an unexpected loss of balance revolving in the whole body touching the ground or lower level. But what I'm really talking about tonight is that it can be a slip or a trip where at least one body part touches the ground or other surface. So not that we come resting to the floor, that we're losing our balance, that we're actually coming to like falling into the wall or falling into the chair. Those can be defined as a fall as well. And that's important because that's where that underreporting comes in. We know that a history of falls people report a significantly poorer physical and psychological health. compared to people that don't fall. And it's also important because near falls can lead to a fear of falling. So how do we maintain our balance? Balance control is a complex motor skill which is derived from multiple systems. We know that many areas of the central nervous system are affected in MS, and this can affect our postural responses to maintain our balance. So if we look at this diagram here, if we're moving around our environment, this is where we can fall over or successfully maintain our balance. How we maintain our balance is we have sensory information that comes in. We have our vision, which equates for 10% of our postural control in a well-lit, stable surface. We have our proprioceptive system, which is the awareness of our joints, muscles, and position in space, and our vestibular system, which is our inner ear function and associated connections, which tell us where our head is in relationship to gravity and where we're moving in space. That information comes in and is processed by the brain, goes through our cognitive system, and then that sends signals out to the body to move our musculoskeletal system, our joints, and our muscles. So we move and maintain our balance in our environment. When one of these are disrupted, then we will have loss of balance or a fall. And we know that falls in the MS population commonly result of accumulation of these impairments. So when we're looking at falls prevention, we really need to be looking at a multifactorial risk assessment. That would involve a comprehensive evaluation to assess all the modifiable risk factors that impact on our balance. We would need to be looking at the environment, so identifying hazards in your daily surrounding that could impact on your balance or cause a falls risk. Ideally, you need to be looking at medication and checking for side effects that can affect balance. And we also need to be evaluating the psychological impact of falls. This is because any level of concern, even minimal concern about falling, is significantly associated with higher odds of experiencing at least one fall. And fear of falling itself represents an impactful and actionable concern and should be addressed and identified promptly. A fear of falls can impact participation, it can increase social isolation, and also creates difficulty performing activities of daily living and creates a further falls risk. In fact, if you look at the fall cycle here, at any stage you can see it's a circular diagram because each stage leads to the other. So even if you haven't had a fall, the fear of falling can lead to you being less physically active, which can lead to loss of muscle and bone strength. You can become unstable with your walking, and then you're at higher risk of falling, and then you're likely to fall, which creates more fear, and so we go around in the circle. So it's important that we address fear of falling to stop the sequelae of events from having further falls at any number of these places. So if you identify unstable gait, you might want to start there. Excuse me. So we want to be thinking about our risk assessment and looking at what are the modifiable risk factors that we can address when we have balance deficits or we are falling. So we know balance can be impaired by multiple factors, including cognition, visual impairment, vestibular impairment, the inner ear, motor or muscle impairment, sensory and coordination function. And these factors may vary among individuals. It is possible that a certain lesion location could result in impairment and that be the primary contributor to balance impairment, or it could be that there are multiple factors that are causing someone's balance issues with MS. We're looking at the motor impairments. If Muscle weakness reduces the ability to generate adequate force for postural corrections, and weaker core and lower limb muscles are crucial for maintaining an upright posture. If our posture changes, it means that we're unable to keep our center of mass in the right position, so it's harder for us to balance. And if we've got weakness on one side, it can create asymmetries that mean it's harder to shift our center of mass and gravity when we are moving about our environment. With coordination difficulties, this can disrupt the timing and sequencing of compensatory strategies. So if we lose our balance, if we're not coordinated, might not be able to move as fast as we need to correct for that perturbation. And decreased coordination can impair smooth weight transfers during walking. Balance impairments themselves, as we've said, balance control is a complex motor skills, but the neural lesions and degenerations due to MS affect the signal conductivity along the nerves and the integration of the peripheral nerves, the spinal cord, and the brain itself. This can cause delayed postural responses due to the delay in the connectivity or conductivity, and it impacts our balance as well. If you're receiving that sensory information late, then you will respond to this information late, and therefore it shows what you get is a reduction in the reactive balance responses. And in one study in 2022, what they saw is there was a change in what they called sway complexity. So that's the automatic postural response. So when we lose our balance, we should automatically respond to that by stepping or using our ankle or hip strategy to keep ourselves upright. What it was showing that this can be significantly reduced in early stage MS when it's compared to more healthy subjects. This suggests that there is a less automatic and more conscious control of balance, which can further impair our balance responses as well, because it makes us more tired and we have to use more of our brain power just to keep ourselves upright against gravity. With neuromuscular fatigue, we know that as muscle endurance decreases during the day or with prolonged standing or working, this can impair performance and increase balance deficits through the temporary weakness and coordination deficits that can come with neuromuscular fatigue. We know that with motor control, we disrupt automatic postural adjustments, and there's an impaired feed forward mechanism, so you can't always anticipate balance challenges as well. If you've got ongoing spasticity or loss of flexibility and loss of range of motion within the joints, then that can create abnormal posture, and biomechanically, structurally, you can't move in the ranges of movement you need to maintain your balance for recovery steps. And if you're having spasticity and spasms, this can cause unpredictable muscle contractions that will also disrupt your stability. With a decreased reaction speed, this can slow down those protective responses when there is an unexpected perturbation or loss of balance. And it extends the time needed to process balance threats. So if you did lose your balance, the speed to know that you've lost your balance isn't there, so we can end up with more falls. If you're having issues with your pelvic floor, this can create urgency, which can prompt rushing to the toilet, which can create an increased falls risk in itself. And we know that with a weakened pelvic floor, that also impacts on our core stability, and that will adjust postural alignment, and also that poor core stability will impact your postural control. Other motor impairments, we look at low blood pressure. If you stand up that quickly and your blood pressure drops, it can cause lightheadedness and dizziness, which can lead to falls. And foot drop. So if you've got weakness that causes a foot drop, that can increase trip rest during when you're walking, or alters normal foot clearance and heel strike when we're walking as well. So it means you may find it harder to walk on uneven surfaces, creating that falls risk as well. It also changes your gait pattern, so you're not moving in the way that you might normally would if you didn't have the foot drop, so you're can be more unstable. As well as motor deficits, we need to think about the sensory deficits that we talked about as well, sensory impairments. We talked about the sensory information coming in the proprioceptive system, the vestibular, and the visual system. Visual impairments can result in blurred or double vision, which means that the visual information coming in is incorrect and the brain can't use that appropriately. There's also can be color and contrast recognition problems. And a study in 2014 found that 50% of people with MS develop optic neuritis, which can lead to some of the double vision, which impairs your vision. So you're unable to use it effectively for balance. Studies have shown that vestibular deficits or dizziness is reported in 49 to 59% of people with MS. And this is likely due to central integration issues rather than peripheral issues. So when we talk about the vestibular system, we're talking about the inner ear function plus all its connections through the brain, of which there are many. And the role of the vestibular system is to coordinate our postural responses in relationship to where our head is with gravity. But it's that central integration that often becomes a problem within MS, although a lesion directly affecting the vestibular nerve could cause more vestibular function deficits. When you have a problem within the vestibular system, this can cause a mismatch of information, which means it will cause dizziness within the brain. Dizziness can also be caused by a condition called BPPV, which is when you get crystals within your inner ear. And often people will talk about vertigo when they turn over in bed. This will also lead to balance deficits. And dizziness can also come from medication as well. So it's important when you're looking at sensory deficits that you're trying to identify where are these symptoms actually coming from. Degeneration of the neural pathways can also affect sensation. So if you can't feel where your feet are on the ground, it's very hard to manage uneven surfaces or even flat surfaces because you're not getting that information about where your body is in space. Or it might make it easier for you to trip over because you're not feeling where you're walking. The risk of falls and multiple sclerosis extends, though, beyond the physical impairments to include key behavioural and environmental factors. Task urgency, like rushing, compromises our motor control and attention to balance, and it prevents some of the adequate compensatory strategies that we need. So that can cause an increased risk of falls. If we look at our environment, everyday obstacles can become significant hazards. Things like doorways, rugs, furniture can create complex navigation demands when we have impaired mobility systems. Again, surface conditions, uneven, slippery, or changing surfaces demand a greater sensory integration and more rapid access of our motor strategies to maintain our balance adjustments. And this can exceed capacity of the MS system when it's already compromised. When people have ongoing fatigue, whether that's neuromuscular or cognitive, we know that poor activity pacing and insufficient rest periods compound that, and that can reduce the amount of cognitive resource for balance monitoring. So when we've got a balance deficit, we actually use more of our brain power to move around our environment, and we take up some of our already precious attentional resource. So if having to pay more attention to our balance, it will make us tireder as well. And emotional influences or limbic activity influence. A study by Whalen in 2024 highlighted how anxiety and fear of falling creates protective movement patterns that increase instability because we've got tense muscles and disrupted motor control. And we know if we're in a more stressed situation, we don't react as well. We can't use our brain power as well. So therefore it puts it at more risk of falls. As well as the environmental and behavioral context factors, we need to think about the cognitive and attentional factors as well. We know we just spoke about the cognitive fatigue, making balance harder, especially when we get tired, because it struggles to keep track of where the body is in space, making falls more likely, especially later in the day. Doing two things at once, that divided attention, means that your brain might find it difficult to focus on staying balanced while doing something else, like talking or carrying objects. And this is why falls can happen with many of our everyday activities. Distraction can cause us to have poor balance and increase our risk of falls. And that's because getting distracted can quickly affect your balance. Unexpected noises or movements or conversations can quickly pull our attention away from what we're doing and can make us maybe not step safely or leads to stumbles and missteps. And then dual task impairments, trouble with multitasking. It means that when you think and move at the same time, if you've got a balance deficit, sometimes something has to give. Either your balance becomes less stable or your thinking becomes less clear. These thinking related challenges and behavioral aspects need to be considered when we're thinking about falls prevention, putting together comprehensive strategies to manage all these components of managing falls and balance deficits. In fact, people who have near falls are at a greater risk of falls in the future, and so it must be addressed. And it needs to be addressed, especially early in the disease course. If you think back to one of my first slides, this is happening very early on. Those changes within the postural control mechanisms is present, even before the need for walking aids. And we know that prevention is better than cure. Doing something and addressing this early leads to more independence and greater quality of life. So what can we actually do to address falls? So if we need to create a personalized fall prevention plan. Beginning early in the disease course, this will help supplement your medication therapy and potentially postpone or slow down the MS-related functional decline. Falls prevention needs to minimize the modifiable risk factors that are the personal, task, and environmental risk factors for falling, and then reduce the risk for injuries. So we need to be assessing not just the falls, but also the near falls and the fear of falling. We need to be doing that risk assessment, then putting in targeted exercises customized to your own ability. We need to be thinking about those environmental adaptations to make your space safer. And we also need to be working on a team approach. So working with your neurologist, your GP, the nurse specialist, physio, and occupational therapist. In fact, part of the team approach is thinking about your medication and doing a medication review. We know that with multiple medications, that can put you at risk of falls. And it's been shown that even taking one medication, such as an antihypertensive that lowers your blood pressure, or psychoactive medications, are considered an increased risk of falls to the risk of dizziness, reduced alertness, slower reaction times that can occur with these medications. Some other medications might need to be considered as well, like spasticity medication, which if you use a whole body medication, something like baclofen, it needs to be tailored correctly so it doesn't create further weakness. And this is why it's so important that you work closely with your medical team when falls and balance are concerned. So going about identifying your specific cause for your falls or balance deficits, I recommend a falls diary. And this is we can analyze what, how, and where you might be falling and identify the patterns and then be able to address them. Key questions you might want to ask in your falls diary is you might even go and take these slides and look at those modifiable risk factors and see which ones apply to you. And then you can actually keep a record of your falls. So when did you fall, the date and time? Where were you falling? So was it indoors? Was it outdoors? Was it in your bedroom or the bathroom? What were you doing when you fell over? So was it that you were doing two things at once? Were you rushing to get somewhere? Did anything in your surroundings contribute to that fall? How did you feel when you fell? Were you dizzy? Did you feel weak? Were you unsteady? Were you more tired than normal? Think about how did you fall? The direction. Was it a trip or a slip, or did you collapse? These can all start to give you ideas about why you're falling. Thinking about were you hurt, and could you get up off the floor yourself, which is really important. When we're doing a good falls prevention program, we should be addressing that you're able to get on and off the floor safely, and because that eliminates some of the fear of falling. And then what did you think caused the fall, and have you fallen like that before? So is this a recurring pattern? So what can we do about some of these modifiable risk factors and impairments? Well, we can do balance-specific exercises, and I'm going to talk about that specifically in a moment. We need to be, if there's weakness, we need to be thinking about strengthening, and that needs to be large muscle groups such as calf muscles, glutes, hamstrings, quads. It may be that your walking symmetry is out, or that you're having problems with your walking, so you need to be doing some walking retraining. Is it that you need to be addressing your foot drop? So we need to be doing exercises for that, or is it that we need to be using assistive devices like AFOs to help manage that foot drop so you're not at risk of tripping over? Thinking about dizziness. So we've already talked about some of those systems. Is it that we need to be giving central calibration exercises to get the vestibular system working effectively? Or is it a peripheral disorder where we need to be doing maneuvers for BPPV or gaze stability exercises for peripheral vestibular deficits? It may be that if you're getting double vision, is it that we need to see the optometrist to look at having glasses with prisms to help with double vision, or looking at that depth perception? And sometimes it might be that you do some vision exercises to help with that as well. We need to address spasticity, so making sure that we've got the correct medication, that we're doing stretching, and identifying what's causing that spasticity. Pain management can be a big thing. If we're in pain when we move, then that can restrict how we move. So taking medication or addressing those musculoskeletal impairments. It may be that we need to be doing dual task training, so actually practicing doing two things at once in a safe environment to expand that cognitive capacity to be able to do those two things. Pelvic floor retraining, and working on bowel and bladder incontinence, especially urgent incontinence, to prevent that rushing to the bathroom with a pelvic floor physio, or maybe using continence products, and cognitive fatigue management and management of neuromuscular fatigue as well. So whether it's using pacing strategies and preventative rest, or managing neuromuscular fatigue with use of ice, cooling. So all those sorts of things can help maintain your balance, but it's about identifying what is causing your impairment and then addressing those. If we think about balance retraining itself, we know in early stages it's suggested that balance executed under sensory conditions and should include preventative strategies aimed at improving fatigue, gait asymmetry, and dynamic balance exercises. But we want to be working on both dynamic and static balance responses. So when we're thinking about static postures, we're thinking about feet together, standing on one leg, and that's when you can bring in some of the integration of the vision and the vestibular systems. Or it might be that you're wanting to do more dynamic work, where you're doing stepping and gait and uneven surfaces. But what the research clearly shows is that training needs to be specific. So you need to be identifying what are your balance impairments and progressing those because that's going to give you the most improvement. Also, when it's specific and meaningful to you, your brain is more engaged in it, so you're going to get better motor learning and better change over time. It may be that you need to look at compensatory strategies with your balance retraining. So if postural responses are delayed, we may need to be retraining the vestibular and visual systems to be more effective. Or if you're overly reliant on your visual system because your vestibular system's not working as well, it may be that we need to work with your eyes closed so you can adjust for that. It's been shown that to get the most effect of your balance retraining, you need volume is important. So you need to be doing a minimum of sort of 40 minutes balance rehab per training session. And of course, you would build up to that, but that would be from a rehab setting. And intensity and challenge is important. When we're retraining balance, we need to do it where we're pushing the balance systems. So yes, we want you to be able to stand there nice and still, but the brain's not going to change when we're standing still. It works on a negative feedback loop. So when you actually challenge your balance, so you might lose your balance or you might sway a little bit more, the brain has something to change and adapt to. So it needs to be set at the right level of challenge to make a change, and that's been shown to be very important as well. As well as balance retraining, it may be that we need to think about using assistive devices. These can improve independence and reduce falls risks. And it allows you time to get out there and be active. And sometimes they might be a stepping stone during a relapse. So it might be that you use Nordic walking poles or hiking poles when you're outdoors, or it might be that you need a walking frame or a stick. It may be that you need to think about having a pendant alarm to increase the safety within your environment, or using ankle foot orthosis to manage foot drops, or a dictus splint to bring that foot up so you're reducing those foot drop. It may be that you need to conserve some energy using wheelchairs or mobility scooters so that you can then use your energy to do other physical tasks so you reduce your risk of falls. Again, it's about finding what works for you as an individual. We also know that appropriate footwear is important. Things like jandals or slides or ill-fitting footwear can cause a falls hazard, and so you need to think about that as well in your environment. And then you may need to look at the environment that you're in. Mats, carpets, pets and rugs can cause trip hazards. Lighting and use of adaptive equipment may be important. So if you're walking around at nighttime and you know that you're visually dependent for your balance because your vestibular system's not working or you've got sensory changes, you might need to have a night light so you can use your vision. Adaptive equipment, so things like shower stools and toilet frames can be helpful to help maintain balance. Or it may be that you need to use catheters and urinary incontinence products so that you're not rushing to the bathroom, so you're able to maintain safety and not have a risk of falls. And setting up your environment as well. So it might be that if you find you have to rush for things or that you get tired at certain points of the day, do you need to have your phone, your water bottle set up near you so that you're creating that safe environment as well? And the New Zealand Health Fi website actually gave us there's a beautiful home safety checklist. And what I will do is I will pop that into the chat so you can access that as well, or you can see that. So you can look to identify the areas in your environment that might need changing. I'm just going to have a bit of water. So this is a big topic. So hopefully you've got some information there. I'm going to answer some questions in a minute. But remembering, falls and near falls aren't just frustrating events. They're important signals that shouldn't be ignored. Each incident gives you and your healthcare team valuable information about specific challenges that need addressing. It's important that we start early with falls prevention strategies, and this can make a tremendous difference. You don't need to wait until falls become frequent or serious before taking action. The sooner you begin addressing your balance, the better your outcome will actually be. It's important that you understand your own unique pattern of your MS symptoms because each person will experience a different combination of challenges that affect balance in individual ways, and knowledge is your first step towards management. Effective falls prevention isn't just about changing one thing, it involves addressing the physical symptoms through targeted exercises, making those small changes in your home, and developing practical strategies for daily activities. And importantly, working through any anxiety about falling that you might affect how you move. For people using walking aids and other assistive devices can be game changers. Rather than seeing them as giving into the MS, think about that they're tools you can expand your independence and confidence while keeping you safer. And remember, no matter where you are in your MS journey, improvements can always be made. But prevention is far better than dealing with the consequences of falls, and research shows that targeted intervention makes a real difference to your balance and stability. Thank you so much. I'm going to open it up to to questions. Here's just a little bit more about us. We've got lots of information online if you're needing some more information. Thank you so much. And I can stop sharing and come back for questions.
Fabulous, Sarah. Thank you so much for sharing your knowledge and your experiences. And what a very small title, falls and balance in MS, for an incredibly huge, broad topic. So you did an amazing job there, summarizing so many different things that impact on MS and falls. So magnificent. Hopefully, a lot of our viewers are sort of having great time to sort of think and work out what is perhaps specific to them as well. And like you say, being proactive is really important too. So fabulous. So now we'll look at any questions, and I'll hand over to Luminita to get started in terms of reading out any questions and popping them your way, Sarah. Thank you.
No worries.
Thank you. Thank you, Sarah. It was absolutely fantastic, so much information, and all very valuable, and things that we need to bear in mind all the time and make our lives easier. We've got a question about spasticity and physio and balance, and if there's any targeted exercises for people that suffer from spasticity.
Yeah, sure. I guess it depends what muscles are affected. So you have to identify that. But again, if it's whole body, like lower limb spasticity, a good standing program is really important to keep the muscles nice and long and flexible and then moving. Obviously, thinking about really good medication management is really important. If you're thinking about more calf, lower limb spasticity, then you'd be looking at calf stretches. Hamstring stretches can be really effective as well, so keeping the lower limb moving as much as possible. So it's hard, like when you don't know which specific muscle groups to target.
Yeah.
Yeah.
Thank you for that. That's very difficult.
Okay.
We've got quite a few members that have, whole body spasticity. They still want to, to keep as mobile and as active as possible, but it's very difficult to exercise, in that situation. And yeah. Another question is someone's asking if you can clarify a little bit more about neuromuscular fatigue and cognitive fatigue. When did this become evident in people?
So I guess if we think about the difference between cognitive and neuromuscular fatigue, if we think cognitive fatigue is really the brain tiredness when your thinking slows. And so that's like feeling tired. And the neuromuscular fatigue is the fatigue the conductivity fatigue that happens when the nerve doesn't the conductivity slows in the nerve and you can get weakness in the muscles themselves. And so you would need to be addressing those separately through like resting for cognitive fatigue, and then also obviously resting for the neuromuscular fatigue, so you're not getting that ongoing weakness when you're having that prolonged standing and movement. And then what you would do is address that through, say, targeted exercises where you would do sort of interval training to help with the neuromuscular fatigue as well.
Thank you. Really helpful.
Right. If there's any other, you can answer follow up from that.
Thank you. Another question is, when feeling goes in my feet, easily to have my feet fall asleep or be on fire with pins and needles when sitting still for a while. High bar stools or breakfast benches are a nightmare, sadly. So I guess it's about some adaptive, I don't know, something in the environment that would help people that have this,
The sensory
yeah,
changes that are happening with maybe sitting for prolonged periods of time.
yeah.
So I think obviously when you can't feel your feet, you are more at risk of falling.
Yeah.
So again, it's identifying why that's happening. If we're sitting down for longer periods of time, it might be, can we move those legs before getting up? Does that change anything? Thinking about that posture, if there's any back-related issues that's causing some of those sensory changes. But again, coming back to that neuromuscular fatigue and the conductivity that can cause some of these sensory changes after being sitting for prolonged periods of time.
Thank you, Sarah. I think someone wants to know if the slides will be made available. And I think, everything's going to be recorded.
And happily we'll share those so people can access those lists that they can look at.
Yeah, excellent. Thank you so much. Yeah, that, as Penny mentioned in the beginning, everything's being recorded and it's going to be in our website in a few days. Yeah.
And just might jump in there, just how you were talking about challenge and balance, which is, really, really important. Just wondered if you're happy to chat about the difference between the challenge that you might get in, say, treatment in terms of a physio clinic versus at home kind of exercises and the sort of the difference there.
So that's really interesting. And I think it's really important that we are addressing challenge when we are doing balance retraining. Definitely when we're in a physio clinic, we are pushing people right on that edge of almost falling because we want to take them to their limits of stability, because that's when we're going to get the most change. But we do it in a graded and supportive manner. So we might put people in harnesses and then we might actually do some more dynamic work where we push people outside their stability, or we get them walking and we give them those external perturbations so they're having to step and really make those changes. Where at home, if you're just doing balance exercise, you have to be a lot safer with what you're doing, because obviously you don't have that external support. You don't have harness, you don't have belts necessarily to do that. So you often do a lot more static based type exercises at home, or exercises would be holding on. So there wouldn't be quite as much change that would happen from those home-based exercises. Both are vitally important because, yes, you might come into physio and do your 1 hour session a week, or your exercise class. You still need to be doing that at home and practicing those, but setting yourself up in a safe environment. So that would be some of the main differences when you are looking between the two.
Thank you. Big differences, yeah. And there's another question: how to address strengthening of the core exercises?
So that's that can be done a few different ways. Specifically, 'specifically, things like Pilates can be really good. some of your hydrotherapy work can be really excellent, and that's another really good, which I didn't actually mention, but can be really good for balance training because you're in a really safe environment. But you want to be thinking about the core muscles. So sometimes you can be doing like you look at basic sit-ups, or like you could do like Superman type things if you went down on the floor, or sometimes if you're sitting, it might be that you're actually just working on engaging those core muscles as well through like pressing down on a desk or a wall. It depends on what level you need to be doing those core exercises at.
Thank you. Yeah.
Absolutely. Yeah, thank you. And are you happy to tell us a bit more about those central calibration exercises that you mentioned in terms of what is that? What does it look like or sound like? Yeah.
Yes. So I guess when we're looking at the vestibular system, you've got the peripheral vestibular system, and then you've got the central system. Sometimes if it's more that central processing, you need to be using some of the compensatory strategies. So rather than just doing your straight gaze stability exercises, it might be that you're doing more head-eye exercises or remember target type exercises. So you're bringing some of the other sensory systems in to be doing that, so calibrating that central system. But it also might be that you're doing some of the peripheral stabilization where you're doing lots of head movements and using the vestibular system, so you've got more awareness of where you are in space. And sometimes we'll use things like weighting or other sensory strategies to help people be up regulating their other systems, or utilize it. Like if we're over relying on vision, we might need to up-regulate the central system by, say, holding a weight or using a weight vest to then help us use our vestibular system more effectively.